Well, thanks so much for joining me today for episode 3 of season 5 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. As always, I want to begin by thanking and acknowledging the SCAN Health Plan and SCAN Group for generously supporting this podcast. Of course, I do work for a subsidiary of the SCAN Group. And very exciting update with SCAN. As of this month, January 2022, SCAN is not only the largest independent Medicare Advantage plan in California, but is now available to residents of nearby Arizona and Nevada. So great to see SCAN expanding its footprint. So my guest today is a very interesting guy, good friend of mine, Dr. Elliot Hirsch. He's a plastic and reconstructive surgery. He did his medical training at the Keck School of Medicine, the University of Southern California, and Northwestern in Chicago. He is very academic. He has published over 40 peer-reviewed medical journal articles and book chapters, and also holds a couple patents in plastic surgery techniques. And as we'll talk about, he is a very artistic person. So today we're going to cover a number of topics related to the field of plastic surgery, one of which is that plastic surgery is a misunderstood field, although it's often associated with high-end cosmetic procedures, and we'll certainly cover some of that today. It also does a lot more than that, as Elliot will describe. In addition, Elliot's going to have some very practical tips and guidance for patients who are considering the pros and cons of trying out a cosmetic procedure. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Also search and subscribe to the Healthy Skeptic MD on YouTube. And with that, we'll jump right into our discussion with Dr. Elliot Hirsch. Well, welcome to this Healthy Skeptic MD, Dr. Elliot Hirsch.
Thank you for having me on the show.
All right, Elliot. Well, could you begin by just giving us a little bit of background about your medical training?
Sure. I went to college in Baltimore at Johns Hopkins and then had enough of the East Coast cold. So I came back here to USC, the better of the two med schools in Los Angeles. And I did 4 years there and then went to Chicago for 7 years and did a integrated plastic reconstructive surgery residency. And now I am back here in private practice in Los Angeles.
You know, a lot of my listeners are on the East Coast because I'm originally from there, and they can't tell the difference between USC and UCLA. So it probably doesn't even matter what you said. But so, Elliot, you are a plastic surgeon. It's often said in medicine that medicine is both an art and a science. Definitely something I found to be true, but that is quite literally the case in plastic surgery. And you actually have an interest in art. And could you tell us a little bit about that?
Sure. When I was in med school, I was looking at the different types of surgical specialties. I knew I wanted to do surgery, but wasn't exactly sure which. And I remember rotating through with the plastic surgeons and spending some time with them. And I thought what they did was really interesting. It was not just about removing a broken bone or an appendix or something like that. It was more of like a creative specialty where you learn problem-solving skills, and you apply those skills to fix wounds, to change people's appearance. So that's what was originally kind of interesting to me about the field, was that it's really a problem-solving specialty. I remember talking to the residents about this, and they said, well, you know, all plastic surgeons are usually good-looking, funny guys. And so you've got one of those, so you might have a chance. So I didn't bother asking which one, because I think I knew the answer.
I'll give you credit for both, for what it's worth.
For sure. Well, thank you. It's generous of you. But from the artistry of it, it's interesting because in a lot of the plastic surgical procedures we do, there's no defined outcome. It's not like orthopedics where if you have a broken bone, the bone is fixed. That's the success of the operation. This is very much of what is the image that the patient has in their mind? And is that image that the patient has in their mind something I can deliver? And if so, how do I get there? And so I have a background in drawing, but more in music than anything else. And all of kind of that stuff fitting together, and also background in behavioral biology, gives you a better understanding of the patients. All that kind of combined is how the artistry of plastic surgery fits into the final result.
So I probably should have said this as a point of disclosure up front. My wife and Elliot went to school together. Was it grade school and high school? Or Yeah.
Middle school, high school, all the way to 12th grade.
So that's actually how I know Elliot. And she said she used to look over his shoulder, because I'm sure she was paying great attention in class. And he used to be doing these doodles that, all of us doodle in school, and his were like these amazing pictures. So, very, very artistic, right brain side of you, I guess.
Well, I also sat behind her in band class. I don't know if she told you that, but in band for probably 3 years, I sat behind her, and I played trombone and she played saxophone. And so I was always poking her chair with my slide of the trombone.
I'm totally a left brain person, so I always have a lot of respect for people who get music and art, and definitely seems like the right field for someone with a interest in medical science and an artistic side to them.
Yeah, absolutely. Yeah.
So, I think plastic surgery is in a lot of ways a misunderstood field. It's there's a lot of association with the high-end cosmetic procedures, breast implants, facelifts, nose jobs, and so forth. And there's certainly a good component of that to it. But there's also a lot of wound care and burn injuries and reconstructive procedures after cancer treatments. Could you just give us a little bit of overview of what's in the scope of a plastic surgeon?
Yeah, sure. I think you're 100% correct about that. And we'll go ahead. We should draw a distinction too between plastic surgeons and cosmetic surgeons, because they're very different. So when you talk about plastic reconstructive surgery, it's a very broad field. It encompasses not just the aesthetic types of operations that you talked about, like breast augmentation, rhinoplasty, facelift, abdominoplasty, liposuction. It also encompasses reconstruction. And so the purpose of reconstructive surgery is to restore the body to its to the best possible appearance after something like cancer, trauma, congenital defects, that type of thing. And so from pediatric plastic surgery, there are cleft lip, cleft palate, craniofacial deformities, limb length deformities. Burn surgery is part of plastic surgery. Things like trauma reconstruction, maxillofacial reconstruction, and then, of course, the cosmetic ones that we mentioned, breast cancer operations. So some people would say that plastic surgeons are the last true general surgeons that can operate on any part of the body, where general surgeons these days tend to be more focused on the GI tract.
Yeah, it's interesting. I do homeless healthcare. I'm leading a homeless medical group, and some of the patients we have really severe wounds. And the plastic surgeons are the best people to handle those situations. A lot of people think, oh, they're doing facelifts all the time, but they're also helping some of the neediest patients with wound care issues, burn injuries, and other things. And there's the whole spectrum. So it really is an interesting field.
I could tell you any number of stories from a residency where I was at Cook County Hospital in Chicago for a couple months. I mean, I've told you some of them, but I could show you pictures and things where, anybody who thinks that we just do, like we said, breast augmentation and tummy tucks, it's very far from that. But that being said, let's touch on cosmetic surgery versus plastic surgery, because it's very different. So somebody who is a plastic and reconstructive surgeon, like myself, I'm board certified, which means I did an accredited residency program, which for me was 7 years. There are some programs that are fellowship programs, which are typically 3 years, and that's after general surgery, after ear, nose, and throat surgery, something like that. These are all fairly long programs, very rigorous. We do thousands and thousands and thousands of operations. The board certification is the highest level of accreditation that you can have according to the ACGME, American College of Medical Graduate Education. But then there's the cosmetic surgery. So when somebody's a cosmetic surgeon, it could be a OB-GYN, it could be a dermatologist, it could be a family practitioner, it could be anybody who did 1 year of additional training specifically in cosmetic procedures. Recently, they have a board of cosmetic surgery, the American Board of Cosmetic Surgery, but this board is not recognized by the ACGME. And so I have taken care of many patients over the years who have gone to cosmetic surgeons and had problems. And most commonly when we say, well, this person's not a plastic surgeon, the patients don't know. And there's a big push right now about truth in advertising in medicine. This is one of the main fields that we see this conflict.
That's interesting. I actually have to admit, I was, despite being a medical professional, wasn't aware of that distinction.
Well, a lot of anesthesiologists I work with, we have the same conversation, and they say, oh yeah, I was working with Dr. So-and-so. I say, oh yeah, they're not a plastic surgeon. They're like, really? And I say, oh yeah. I mean, they look up their website. So it's not, even within medical professionals, it's not a clear distinction. It's just something that plastic surgeons we know about this, and it's a big issue, but we can't, there's a limited amount we can do about it.
Well, I have a loaded question for you. It always comes up, a patient of mine will go to the emergency room and they'll have a facial injury. And is it okay for the emergency physician to sew it up? Or every time it involves the face or a cosmetically sensitive area, do you need a plastic surgeon? And are plastic surgeons really better than the emergency room doctor stitching it up?
That is a very good question. And the answer is it's not so much of the person doing it, it's more of the technique used. So there have been many, many studies on this. And all the studies have kind of shown the same thing, that if it's proper technique, clean the wound, careful approximation of the tissues, and then good wound care afterwards, then you'll have an equivalent outcome regardless of who's doing it. So one thing, though, that I think is important is the wound care afterwards. And so many patients over the years who've been sutured by the emergency room, we come in, we take care of the wound, we get proper wound modulation afterwards, scar treatments, silicone gels, silicone strips, microneedling, laser treatments, and you can get to a good outcome.
And how much of wound healing is genetic? I've heard that, some people are just more prone to scars and other people less so. Is there truth to that?
Absolutely. There's a big genetic component, and that's more about scarring than healing. So I would say healing is if you're going to heal the wound after the injury, you're going to heal unless you have like an intrinsic deficit in your healing potential. There are different genetic diseases that can cause that, or patients who are on prednisone, steroids, certain transplant medications can cause defects in healing also. But the actual scarring is highly genetic. Asian patients, African American patients, even Native American patients are some of the most hypertrophic scar formers. So that's a very strong component of it.
So Elliot, you've fallen into a really, what I think is a very interesting niche in the field of plastic surgery. You do removals of breast augmentations when women want to reverse those procedures or need to reverse those procedures. Also, you help fix augmentation and breast reconstruction procedures gone wrong. Could you tell us a little bit about the types of work of patients that you see?
Sure. Yeah. It's funny. You're absolutely right. I fell into this. I did not come out of training, expecting to do 90% of my surgery is revision breast augmentation. I think there's a couple of reasons for it. In Los Angeles is one of the most common breast augmentation places in the country. Miami, Los Angeles, New York. Every year in the United States, there are 300,000 women who get cosmetic breast implants. So this has been going on for many, many years, since the 60s, 70s, 80s, 90s. So there are millions and millions of women who have breast implants. And now one thing that we're very cognizant of is that breast implants don't last forever. And so there is, I think, a critical mass of women who've had breast implants for 10, 20, 30 years, 40 years, who now are getting up in age. They're getting into the 60s, 70s, 50s, and realizing that they may need more breast augmentation surgeries if they simply replace their implants. And so the other thing is that the breast will change over time. The breast is not always going to look like it did after the implant was placed. And so the soft tissue changes, the skin changes, you can gain weight, lose weight, pregnancy, babies, all these things can change the breast. And so it's just a huge area, and you see such a wide variety of shapes and implants that this has become my niche for sure. And I do, several hundred revision breast implant surgeries every year, removing, replacing. I do primary augmentations too from time to time, but the revision ones way outnumber the other ones.
And how often is it that the woman just is not happy that they had the procedure in the first place? They regret doing it and they just want it taken out?
I can tell you off the top of my head, I can think of maybe 2 patients in the past 5 years that I've seen who had breast implants within the past 3 to 4 months and said, I made a mistake, I want them out. And each of those 2 patients, we had them think about it more. We had them talk to a therapist to just kind of work through what they were feeling, work through their implants, kind of adjusting to this. And both of those 2 patients, after a full year had passed since their augmentation, they wanted their implants out. And at that point, they'd undergone several months of therapy, and so I took them out for them.
Part of what I was getting at with that question, are there some unintended side effects or concerns that women don't appreciate fully about augmentation before they go into the procedure that, they really should be mindful of before they move ahead?
It's a funny thing because at the time of the augmentation, it's one finite point in time. And then if you look at the patient satisfaction studies after breast augmentation, it's one of the highest satisfactions. Over 90% of patients are very happy with their breast implants after 1 year. But like everything else, life happens. You gain weight, you lose weight, you have issues with the implants. There was recently FDA had this ruling about the patient labeling, the patient notification. So now when patients get breast implants, they have this massive booklet that they have to read through. They have to initial. We discuss it with them. So these days, I think it's less of a concern about informed consent and understanding what's going to happen, but it's physically the act of putting a foreign body into your chest and the heaviness of it, the weight of it, the way that you can feel it when you move, when you run. It's not just about the look, the feel. Sometimes implants get hard and uncomfortable. So there's a lot that goes into it. And I think it's hard for some patients to really grasp what this is before they put their implants in.
Yeah, that's interesting. So a woman may be very happy with it at the end of a year, but 20, 30 years later, the situation may be very different and there may be a need to readjust things at that point.
Yeah, absolutely. And that specific scenario that you mentioned, again, many, many patients. Dr. Hirsch, I loved my breast implants for 5 years. Then I had my kids. And, now I'm a little older. I'm in my 50s. Breast size doesn't matter to me, or I don't like the looks I'm getting, or my neck hurts, my shoulders hurt. Can you take them out? Can you do a lift? So that's probably the number one reason that I remove implants, is that over time, patients are just tired of them.
So another common question I get from primary care patients who are considering it. Is there a concern about implants in breast cancer, and specifically about screening for breast cancer? Does it make it harder to identify breast abnormalities in mammograms if you have implants?
They've actually, believe it or not, they studied this too, and the results of the studies would say that there is no difference in breast cancer screening when the breast implants are in during a mammogram. Interestingly, and there's kind of different reasons about this, but patients who have breast implants tend to have a lower rate of breast cancer than the general population. One thought about that is that the breast tissue can be compressed by the breast implant, where the skin is more of a rigid envelope and the breast implant is pushing against the skin. And so that the breast tissue tends to atrophy. Less breast tissue, potentially less breast cancer. Another thought is that the metabolic activity of the breast tissue is actually lower because a breast implant is cold. It doesn't have the same warmth as the body. And so because the tissues are cooler over a long period of time, theoretically there's less metabolic activity and potentially less breast cancer. So that's not really well understood, but it's an interesting link that's been identified.
So, as I've progressed in my medical career, I've become a greater advocate of cosmetic procedures. I've seen the value that can really have in someone's self-confidence. But I've also seen people get obsessed with these cosmetic procedures, and they do another one after another one, and they get in a cycle. And no matter what you do, it just leads to more frustration. I'm sure that's true both for the doctor and the patient. How do you get that balance right between picking people who are going to really get value from the procedure or versus those who are just going to become a spiral?
It's all about expectations. And if you have a patient who, like you said, has something very specific, for example, I've always had a bump on my nose. Can you shave the bump down my nose? No problem. Very straightforward. We can do that. I've always wanted my breasts to be bigger. They never really developed. I feel self-conscious wearing a bathing suit. I want to be able to fill out an evening gown. My breasts after having kids, my breasts are saggy. I want them to be lifted. My tummy has a lot of extra skin after having my kids. These are all very discrete, focused issues, and they're all fixable. Compare that to somebody who comes in and says, I don't like the way my nose looks. Okay, well, what about it? Well, I've had 3 different rhinoplasty operations, and it just doesn't look right. And I can't really tell you why. I just want it to look better. So, alarm bells, you start ringing a little bit, thinking about, okay, well, what specifically is it? Or, why did you have 3 operations and what happened? So there is a spectrum of patients, and the ones who have the best results are the ones who most clearly can identify what the issue is. We can match a procedure to it, and we avoid patients who may have body dysmorphia or other conditions where no matter what they do, they're not going to be happy with it.
You'd mentioned therapy as a part of the process that you use when evaluating patients for a procedure. How do you use therapy, and how should it be used in someone considering a cosmetic procedure?
Yeah, good question. Realistically, it should probably be used more than it actually is. The patients who benefit the most from therapy are the ones with body dysmorphia, where, again, kind of the classic patient would be somebody who has something very simple, but it really bothers them a lot about it. Like if they have a mole on their forehead and they're obsessing about this mole and it really drives them crazy, and it doesn't really seem like that big of a deal, that's kind of your classic body dysmorphia patient. And we know that if we operate on them and remove that mole, they're going to find something else. And it'll just be something else and something else. And so the answer for them to get them feeling better about their body and realize that the mole is not that big of a deal is therapy. Therapy can also be useful after a procedure where, for example, a cosmetic procedure where the outcome is good, but the patient's having trouble adjusting to it. Or in certain reconstructive situations after breast cancer, I send all of our breast cancer patients to therapy, to support groups, because it just helps them kind of cope with their diagnosis and help them move forward and kind of put their cancer behind them, realize it's part of them, but it doesn't define who they are.
Well, you said it a lot clearer than it has been in my mind. But when I have a patient who asks for a cosmetic surgery referral, that's sort of what's going through my mind. Is it a specific issue that I really think is interfering with their life and could really be improved with a procedure? Or is it more of a general dissatisfaction with other things about their lives that are broader? And then the treatment is very different. It's probably more therapy and mental health, addressing those underlying root causes.
Definitely. But at the same time, I'll tell you 2 stories from residency. One of them was a patient who had a huge mole. Like, she was an Asian patient. She had a really big mole, and there was hair growing on the mole. And she was young and fairly attractive, and she wanted Botox. And I was a resident. She had some wrinkles. Botox, no problem. I said, well, how about that mole there? And she said, that's actually in our culture, it's considered to be good luck to have that mole with the hair. I said, oh, I didn't know that. And so I learned something there and realized, okay, well, to me, it sounded this big mole there, and maybe we take that off. Very simple to do, but for her, it was good luck. It wasn't a big deal. The other story I'll tell you, not one of my patients, but this was a patient from one of the attendings in residency. She had a scar up here between her eyebrow and her glabella region. And he showed the picture and said, the patient told me this scar, and it really bothered her, and she wanted to get rid of it. And you look at it, and it was like, it was a tiny little scar, like a centimeter long, really well healed. You could barely see it. But the reason why she hated it was that she was in an abusive relationship, and her boyfriend had hit her with a bottle in the face and cut her. And every time she looked at that scar, she thought about that incident. And so she wasn't necessarily trying to improve the appearance of the scar, because that probably wasn't possible to do, but she wanted to remove that scar, replace it with a new one to help her kind of cope with what had happened before, so that when she looked at the scar, she'd think about the revision that she had rather than the incident that led to the scar. So a lot of this stuff is kind of subtle, and things like that happen, and it sometimes you don't pick up on it with the patients, but as you talk to them and you learn and you get to know them, it kind of helps you get through, figure out who is, and just kind of how to get through that stuff.
Yeah, that's so interesting. Everyone has little scars from various things that happen. It's kind of funny. You remember in some ways it helps you remember stories. I remember I have a little thing on my forehead from when I fell off a bed when I was a kid, another one from a basketball injury. And most of those are at this point, not necessarily bad memories, even if anything humorous, but I could see if there's something that brings up something you don't want brought up again, that there'd be a greater interest in addressing it.
Yeah. You're not going to get rid of it, but just changing the perception of it can really, again, like you mentioned before, cosmetic operations can help patients improve their self-esteem. It's the same thing with a scar like that.
So Elliot, What advice would you give to a patient who is considering a cosmetic procedure? Maybe you could use breast as an example because that's the one you deal with the most. What are the pros and cons that should go into that decision?
Well, the first thing I would say is make sure that your surgeon is a board certified surgeon by the American Board of Plastic and Reconstructive Surgery. So that's what it should say, not the American Board of Cosmetic Surgery. Second thing is make sure that you have a very clear idea of what you want to accomplish. Because when you talk about cosmetic breast operations, it's going to be some combination of a lift versus an implant versus a reduction, and understanding the differences between those operations, what's achievable with them, and having pictures of what you want to look like will really help the surgeon be able to hone in on the right operation for you.
Elliot, one of the themes of this podcast is evidence. Do the things that we do to patients actually improve outcomes? How is the field of plastic surgery doing in terms of rigorously assessing the impact of procedures on patient outcomes?
It is hard to quantify a lot of the things that we do. That being said, there has been a concerted effort over the past 10, 15 years to use validated scales to assess outcomes. So if you look at the plastic surgery studies from the past 30, 40 years, you can look at this and say, well, this guy likes this technique, but he basically says because his patients do well. Over the past 5, 10 years, 15 years, now you look at the studies and they have something called the breast Q or the face Q, which are these patient-reported outcome validated questionnaires which have undergone rigorous scientific screening. And fairly reliably that what they're saying actually happens is what's happening. And so I think the field in general is doing a better job. A lot of this stuff, though, is difficult because if you take a breast reduction operation and I do it versus somebody else does it, it's not going to be the same. And there's no one way of doing a breast reduction or breast augmentation. There's a lot of different techniques. And so you can't really compare one technique to the other technique because even if I did it exactly the way that the guy down the street did it, there's little nuances that he's doing that I'm not doing or vice versa. And so it's almost impossible to compare surgical techniques to other surgical techniques.
Right. It's not like a pill A or pill B, and
right.
You can rigorously compare them. There's so many other factors, and that in a lot of ways is why plastic surgery is an art as much as it is a science. I'm sure. The other thing, there's been a big push in surgery in general to ask patients the simple question 6 months, a year after the procedure: are you glad you went through it? I could imagine some good studies where you look at the outcomes with that one simple question of the impact.
One of the things, so for our breast implant revision patients or breast implant removal patients, I always tell them if you're not happy, we can always put the implant back in. And in over the past 4 years, I've done about probably 200 removals, revision type things per year, sometimes with a lift, sometimes without a lift. This coming Friday is actually going to be the first patient I've ever taken implants out of that I'm going to put back in. This will be the first one out of probably close to 1,000 of these. So, that kind of speaks about how patients feel about their implants over time. But this was a specific case. She wanted something specific, and she just needs to have her implants back in.
The exception that proves the rule, I guess.
Of course.
So I want to shift gears for our last couple questions here. I've really enjoyed speaking with you, Elliot, about the pandemic. I think you've had a great big picture, 30,000-foot view. And really enjoyed those discussions. So on a totally different note, what's your perspective on how our society has done with managing the COVID-19 pandemic?
When the pandemic first started, I remember you and I were talking about this, and we kind of, there's what we all saw in the beginning was obviously there's a virus. We don't know a lot about it. Out of abundance of caution, we should be as careful as possible. I don't think anybody disagreed with shutting things down, figuring it out in the beginning. That being said, it became quickly apparent that in addition to the physical effects of the virus, there's going to be the economic effects of the shutdown, economic effects of the virus. And then the third part of it was the long-term mental health not just of the adults, but the kids being out of school, not being in their peer groups, not being with their normal activities. We discussed data about pandemics previously, war zones, mass trauma, and believe it or not, the PTSD depression rate in those pandemic zones, in those war-torn areas, it approaches 50%, and it's probably even higher than that. And so now you're talking about 50% of the population with some type of not mental illness, but just adjustment disorder, being able to cope with this. A whole generation of kids has had their school is just really, I hear now they're talking about more shutdowns. And to my knowledge, you would know better than me, have you seen any increased funding for mental health or mental health outreach because of the pandemic? Have you seen this? Or
well, the data has shown a very significant increase. There's been more overdose deaths, addictions, substance use, homelessness rates. We don't have a good count because they just haven't been doing the counts during the pandemic. But I think anecdotally, it's very clear there's been a very significant increase. So, I don't think anyone could deny that this pandemic hasn't hit hard our mental health and our economic health.
Yeah, absolutely. The second thing that again, it's in the early days of the pandemic, gyms were closed. Not even early. I mean, for the first several months, gyms were closed, beaches were closed, outdoor spaces were closed. And as we learn more about the virus, we learned that probably the number one modifiable risk factor is obesity. And I'm still waiting for our public health officials to say, "Hey, America, let's get back in shape." I can tell you, I have so many patients. I gained weight during the pandemic. Everybody gained weight during the pandemic, but we need to lose that weight. We should be exercising, watching what we eat. There should be a big public health push right now towards improving our overall fitness, and I'm just not seeing that.
So where we are now with the pandemic, I won't say everybody, but the vast majority of people believe that this virus is here to stay. It's going to be endemic. It's going to be here with us. How do we start getting that balance right? How do we start shifting from this idea that we're going to try to eradicate it from Earth to how do we live with it in a productive way where we don't adversely impact our mental health?
That's a good question, Mike. I remember, again, talking to you in the beginning of this, initially shut down, close everything down, abundance of caution, and that was all. I totally was on board. I'm still on board with everything that was done early on. I think, without knowing really what was dealing with, without any kind of therapeutic options, it all made total sense to me. But now as we've moved forward, and we say, okay, well, now we have a much clearer understanding of the virus. We have different therapeutic options. We know that if people receive the vaccine, they'll generally do pretty well with it. The boosters, there are different options out there. The goalposts, to me, still feel like they've shifted from we need to mitigate this to we need to prevent everything. We know now that you can't prevent everything. You can't prevent transmission. You can't prevent even if you're vaccinated, your booster, you can still transmit the virus based on the current vaccine technology we have now. Look, there are more vaccines coming out. They may be more effective in longer term immunity, but there's no vaccine for the common cold. Common cold is often a coronavirus. I don't really think it's possible to have zero infections and zero transmission. We know who does well. We know that kids generally do well. And I think that we have to step back from our current track and say, look, there is no way to prevent this. There is no way to prevent infections. It's here. We can hope that we develop better therapeutics. We can hope that we develop better vaccines. But at this point, you hope the virus mutates to something that's less hazardous. You hope you develop better immunity with more infections. But I think that society needs to say, okay, we understand it's here. We need to get on with our lives.
Yeah, my hope is that Omicron will serve as an impetus to have a real scientific rethinking of what our goals are. What, as you said, the goalpost should be, if it's how do we learn to live with this, some of the strategies that like testing constantly asymptomatic people and trying to identify every case, those may not actually be consistent with that goal. And we may shift to more what we do during flu season, which is more like sentinel surveillance screening. So we know when there's upticks and we adjust our policy, but we don't try to quarantine and isolate every single case just because it's not practical or realistic. And the mental health consequences, the economic consequences outweigh the benefits of doing that. So I hope we really have a serious, without too much politics in it, rethinking of this as the Omicron surge winds down.
Yeah, I mean, I agree with everything you said, and it's like you said, it's more of a, hey, we need to look at the big picture here and not simply look at case rates, transmission rates, because you don't even know how many asymptomatic cases are out there. There's no way to know. And what I hear about, we're having testing shortages. To me, it just boggles my mind. Why are we pushing to test everybody? I mean, what if you're sick, then stay home? Just assume it's the coronavirus. Just stay home. You can't test everybody every day. And the other one that really gets me, we talked about this too, are the kids. You and I looked at the numbers about testing kids, and in order to, I remember it was something crazy, but you would have to test because if schools are following basic precautions and being careful and cohorting and trying to separate kids in the classrooms, it was something like you would have to test every single kid in LAUSD every week for like a couple years to prevent one death.
Yeah, if you extrapolate it all out, and that's assuming that everyone follows the quarantines and so forth. If they're positive, LA Unified, where our kids go to school, they just did a test as people went back from winter break. 16% of students and staff were positive. And, the truth is, I don't know whether identifying that is doing more benefit than harm. But certainly it's going to keep some infected kids and prevent some spread of the virus, but it's keeping an awful lot of kids home with some downsides. And it's not clear how much transmission happens in school and how much this is actually going to prevent.
You would like to see more people who are taking a scientific approach and a rational approach, have positions in public health and government, but I agree. It feels to me like it's so political, and it's so hard when people are so emotionally charged when you talk about this. So it's a tough topic, but I just hope that we as a society can figure this out and find a way to move forward.
Well, Elliot, I so appreciate you taking the time to talk with me today on the Healthy Skeptic MD. If someone did want to learn more about your plastic surgery practice, where would they find that information?
Absolutely. You can check us out on the internet at www.hirschplasticsurgery.com. That's HIRSCH plasticsurgery.com. Our Instagram handle is Hirsch Plastic Surgery. Or if you want to schedule a consultation or discuss any of this, give us a call at the office, 818-825-8131.
Well, thank you so much, Dr. Elliot Hirsch, for joining. And
Thanks,
if you
Mike.
did find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it along to others who might be interested. We'll pick it up again in a couple weeks. Thanks again, Elliot.